already on the call with us, which is fantastic. So welcome everyone who is joining us, and welcome to our panelists, especially who are here for our very first COVID-19 town hall. My name is Arti Kreibig. I am a neuroscientist by training. I'm also a congressional candidate for NJ District 5. And I really wanted to put this town hall together because these are really unprecedented times that we're living in, especially for those of us in New York, in Bergen County, in New Jersey in particular, and really all over globally. We are going through a pandemic crisis, the likes of which we really haven't seen in many different ways. We are going to be, and we are currently going through a way of living that we haven't ever had to do, and we haven't had to do quite so abruptly and suddenly. And we are going through a crisis that is related to public health that the whole world is going through, that in some ways we see coming, and in other ways is highly infectious, and has had so many implications for all of us in all different ways, in terms of our health, in terms of our social life, in terms of whether or not we're working, so economically, in terms of whether or not we can hold each other's hands, the basic level of human connection. And this is what makes it, I think, particularly disturbing to us as human beings. So from a scientific and medical point of view, COVID-19 is something that when I hear from our constituents, from folks who are in Bergen County, from folks who are in NJ5 and Sussex and Warren, Passaic as well, there is a lot of misinformation out there. There are a lot of questions about what this means, to have it, to not have it, who's susceptible, still how folks are how it's transmitted, and really what we should be thinking. And there's a lot of anxiety. So I wanted to put this together. I really wanted to share and have experts, scientific and medical experts here, share about really how this pandemic crisis came to be, a little bit, where we are right now, particularly in New Jersey, particularly NJ5 and Bergen County, and what we should be thinking of for the path forward. I know that a lot of us have been in lockdown or in social quarantine or restricted movement for about a month now. And I know that a lot of us are feeling like the restrictions are onerous. And I'd really, like to talk about that at the end. So I'm going to introduce my panelists before I have them speak. We have Dr. Stanley Weiss, who is a professor of epidemiology at Rutgers, actually at New Jersey Medical School, Rutgers. He has had decades of experience in epidemiology, so I'm particularly thrilled that he's here. His expertise is going to be helpful, and I'd love to hear his insights from working on the HIV pandemic, and what that can tell us about COVID-19, and how we should be moving forward and how we got here. So thank you for that. We also have Dr. Thomas Kreibig, who also happens to be my spouse. He is the chief of neurology at Holy Name Hospital. It is the epicenter of the COVID-19 cases in Bergen County for sure. And I would say in all of New Jersey right now. And so he'll be sharing a little bit from the front lines and talking a little bit about how things are going in Bergen County. And it's also my pleasure to welcome Dr. Sujana Chandrasekhar, who is ENT and a distinguished colleague as well with decades of experience, who's an otologist and a neurotologist, and clearly has a very cogent understanding of the kinds of things that we're doing, particularly with a respiratory illness. So I'm eager to hear what she has to say from the front lines in New York as well. So welcome all of you to this panel. Thank you so much for agreeing to be part of it. One of you did not have a choice. The other three did. The other two did. And I really appreciate you being here. And so I would love to, I would love to start with Dr. Weiss, and I think everyone's going to, all of our panelists are going to speak for a few minutes, and then we're going to have a discussion on some of the things that we talked about. And so thank you everyone ahead of time for those who sent questions, and continue to send them, and we'll be answering them as the panel goes on. Stan, the floor is yours.
Hi. So I did some training at the Centers for Disease Control, and then I moved on to do a fellowship in what I thought was going to be studying cancer-prone families at the National Cancer Institute. But it was in the early days of the AIDS epidemic, and I rapidly got enmeshed in much of the early epidemiology. And I got a chance to see many of the missteps that were taken, and assumptions and hypotheses people put out, and which were later proved wrong. So with that as background, in the events just this past February, I was hearing some of the news reports, and it became clear to me that there had to be transmission of this novel coronavirus, both by people who were asymptomatic, who felt well, and also potentially by fomites, inanimate objects on which they would have had contact. But continued to mull along with what my daily routine was, which was always hectic. And I had my rude awakening about the pace of what was happening just about 5 weeks ago. I got at 8 a.m. from a colleague a copy of a report. And as I read it at 8 a.m., and I'm not the most awake person at a.m., it woke me up. It was long. Normally I teach students for several decades critically reading articles. I enforced them to print everything out. We cross compare every page. It was clear in reading it through that this was a game changer in terms of the modeling that was done. So it's a long paper, but I want to show one thing from it. It's a model that they put forward in black, where if nothing was done, and then if there was some social distancing put in, and the upshot was that a single day's delay in intervention meant that would be 40% more cases of COVID-19 infection. And that also meant 40% more deaths. It meant that we didn't have the luxury of waiting around. We needed to implement at the right time, which meant urgently changes. That was not a sense of urgency that I'd seen expressed before that, although as I looked back, there were some other papers which were a bit less prestigious than that had suggested. What was happening was that we were getting data not just from China, but from Italy. And the data from Italy was very disturbing at the rapidity at which events were occurring and led to new modeling. Less than a week later, so that was about, I think, Wednesday, around March 11th. And I rapidly posted that article, both on Facebook and LinkedIn, two media which I almost never was logging into and almost never had posted to. And there were hundreds of reads for my post because I'm linked to many people within just hours. It started some discussion with a policy group I helped found, an international one. It's now called the International Network for Epidemiology and Policy. We have 25 different international epidemiology societies involved in it, and circulate information to my colleagues on that as well. And we began discussing that paper, discussing as well with colleagues in epidemiology from the American Public Health Association. We saw some weaknesses in that first paper, but we were very concerned on the basic message. So just a few days later, the following Monday, one of my colleagues, who's one of the leaders in public health in the United Kingdom, so we'd been talking for a few days now, sent me a paper from the Imperial College. It wasn't that strikingly different from the other paper, but it reinforced it in even harsher terms. It turns out the Imperial College had done modeling for the current people in government in Great Britain, and they trusted that group, whereas they didn't trust some of the other people. And it got to the top level of their government that same evening that it came out. And that night, they realized they had to rapidly begin changing policy in Great Britain. And it was really
So can you share really what these papers, what about these papers really scared you? And, what was it about that? I would imagine it was that sort of arch, the steep curve of infections and fatalities. That at least that's what struck me when I first saw it. And after you did, and I'd love to hear sort of what was it about that, as an epidemiologist, scared you or made you anxious?
the rapidity of spread.
Mm-hmm.
That I thought there was clearly a delay from when people were getting first infected till they were exhibiting symptoms. So until you were getting case counts, there is a significant delay, which meant that you were seeing a lag in the true epidemic. In addition, we have different ways of modeling in epidemiology how infectious an agent is. And all of these emerging data seem to demonstrate that it was extremely infectious, more infectious than something like influenza. That meant that the potential for one person to rapidly spread to many quickly, no one knowing that it was happening, was a real problem. Their models were consistent with that was what was happening in places like Italy. And so unless you took rapid action, that it would be too late, because as you have this rapid multiplying in the population, you'd have so many people infected that therefore you couldn't even do contact tracing and try to stop it from further spreading. What we typically hope is that you find an individual case that someone might be infectious, you check all the contacts, you can quarantine that person, tell their contacts to stay quarantined so they don't spread to others. This was showing that it was going so quickly that unless you took immediate action, it would be too late to take those types of measures. Indeed, by the time people in the US were more actively reacting to the problem, we saw it was too late. And then you had the complete shutdown issue. As Paul Krugman just was talking on TV last night, if people had reacted a few weeks earlier, which is when people were really urging it to happen, we probably would have saved trillions of dollars in the economy.
Wow.
Okay. The slowness of rapidity of reacting to data that was becoming pretty clear to everyone who saw the information. And I know of no one who wasn't clear and frightened about that information right at that juncture. And said, we have to do something now. So the extra days and weeks of delay were tremendous. You saw, I just showed you 40% difference in one day.
Yeah, in one day.
One day.
But we are seeing, and I'm sorry, I'm going to butt in just for a second. I appreciate it, but we are seeing, even though there was a delay in response, we are seeing the benefit of the response. And what we're asking people to do is so simple. It's stay home. Stay home. Don't infect other people, because Dr. Weiss is absolutely right. You can infect people without even knowing you're carrying the virus. So what we've done has taken that sort of horrible straight line up and has really flattened that. Even though the numbers are bad, they're nowhere near where they could have been had we not even done this.
Right. And that's a really important point, right? So I think those are the two kind of bookends that we're talking about. The fact is that we should have done something earlier and possibly saved a lot of lives. And definitely in terms of the economy, but really, for me, it's about lives and it's about how sick people get. And then on the other hand, when we did do it, that it was the right response. Because I know that a lot of the fallout, especially in Teaneck and Bergen County, when we first shut down and we were first doing that, there was a lot of fear folks were upset, thought it was an overreaction. And I'm sure that's the case with epidemiologists. Like, this is what I hear is if in public health, that if it looks like an overreaction at the end of the crisis, then you did something right. And we're not quite there yet. But clearly, that was important. So I appreciate that, Sujana. Dr. Weiss, did you have?
And I agree. We had to do the shutdown as we were doing it because we were clear that things were advancing so rapidly that was the only option left.
Yeah.
And the message has been put out very clearly by some of our local leadership. People are listening, and we're seeing that that's been effective now in helping to dampen down what otherwise we are confident would have happened.
Yeah, no, and I totally appreciate that. Thank you so much, Dr. Weiss. I'd love to hear, so we've set the stage for, we should have done things earlier. We got this rate of infection that was already high, and we didn't realize it because there was this delay, as Dr. Weiss mentioned, in understanding or in getting the infection in having the symptoms for those who actually do exhibit the symptoms, and getting this rapid rise. So I'd love to hear from Dr. Krivik about what it looked like on the ground for you in Bergen County, what it looked like in Holy Name, and from there where we are now.
Hi, hello everybody. It's nice to be here for this town hall, and I wanted to share some of my perspectives as someone who works at Holy Name Medical Center, which is one of the hospitals which was at the epicenter of where the pandemic broke out in New Jersey. As we all know, there are more than 60,000 individuals in New Jersey that are known to be COVID-19 positive. Inadequacy of testing, not having enough testing, is telling us that this is clearly not the full number, especially based on a large proportion of people who are asymptomatic. But based on the numbers we know, we have that in Bergen County alone, there are more than 10,000 individuals who have been infected with COVID-19, and unfortunately, more than 500 people have died. And so what I'd like to share to start with is a story. And I want to tell a story about a gentleman named Andres. Andres worked in food services at Holy Name Medical Center. He was an affable guy who always had a smile. And I saw him just about every day. And he was infected with COVID-19 and ended up being hospitalized. And very sadly, unfortunately, he later died. I think this is part of when it really became very, very real to us, that someone who is in his early 40s could die of this. I think that this is challenging the misconception that this is, simply a different version of the flu. And people are understanding that people who are younger and people who do have other risk factors to their health are at higher risk, and that we have seen, unfortunately, a lot of tragedies. And I would say it's difficult, knowing that we have doctors, we have nurses, we have respiratory therapists at Holy Name Medical Center who have gotten sick, either through contact from patients or community spread. Because of the fact that there's asymptomatic transmission, it makes it very difficult to contact trace, especially once the COVID-19 infection got a strong foothold within this country. And so that makes it particularly challenging. Another thing that I would like to just sort of touch on just in these opening things is, one of the big concerns is for healthcare professionals is PPE, or personal protective equipment. So that includes gloves, that includes disposable or laundered gowns, and that includes surgical masks and also so-called N95 face masks as well, which are probably the best thing that most people can use for the most part to help for healthcare professionals who are dealing with people who have a active COVID-19 infection. And, there have been a lot of stories about concerns of having enough PPE. I have to say, thankfully, that right now we still have enough PPE at Holy Name Medical Center. However, supplies had run low. At one point, they were telling us, we only had 4 days left. And then, 2 days later, we still only had 4 days left because, they were aggressively trying to get more N95 respirators, make sure that we had a system for laundering gowns. Basically, we're using surgical gowns, which are being laundered, as well as some disposable ones at times. But, there are a lot of healthcare professionals throughout this country who are facing a lack of PPE and put themselves at enormous risk for infection. So
no, I'd love to hear like very quickly about how, and maybe Dr. Chandrasekhar can talk about this when you speak, and about how folks mobilized, right? So, and there are a couple of different things. Dr. Weiss, you talked about this, this perceptuous curve that we all looked at, or at least folks looked at, and decided maybe a little bit behind when we should have, that we should be doing the social distancing. We should be pushing hand washing and real hand washing for 20 seconds. As well as, making sure that we're not in contact with each other. And that has absolutely worked to start to flatten that curve in both New York and New Jersey, which we're really thankful for. And I think a lot of folks feel as if, at this point that, we're breathing a sigh of relief that, we can kind of go back to business as usual, which in my personal opinion, loosening those restrictions right now is not the right thing to do. And I'd love to hear your thoughts about that. But I'd also love to hear, how things mobilize, at least, from secondhand information and being next to a partner who goes to Holy Name every day, seeing folks come together and do everything possible. I mean, there's a whole new ICU that was made, 36 bed, facility that was made in Holy Name, and that formerly didn't exist. And I know that has happened many different ways. So, Dr. Chandrasekhar, I'd love to hear your thoughts about how things were on the front lines, and what you think about flattening the curve, as you talked about.
So thank you for inviting me and giving me the opportunity to participate and to learn from my three wonderful colleagues here. So I'm an otolaryngologist. I'm an ear, nose, and throat surgeon. I work with ENT and Allergy Associates. We have 45 or something offices in New York and New Jersey. Few things that we're seeing with COVID. I think I agree, Dr. Weiss. I think the response was not as rapid as it could have been, but when we started the response, I think healthcare professionals, epidemiologists identified the correct course of action pretty fast. And I think Holy Name being an epicenter, unfortunately, in our backyard, really brought that home to us very quickly. The lack of PPEs is a problem. And you hear every governor talking about it every day on their briefings. The lack of testing, which Dr. Thomas Kajak pointed out, is a huge problem because we actually don't know the denominator, right? So we don't know if it's 1% of people get really sick, or 0.1% of people get really sick, or is it 10% of people who get really sick, because we don't know the denominator. It's a funny disease because there's a significant percentage, and the world is flat in terms of information, which is wonderful. It's used to be flat in terms of travel, which was bad because diseases kind of came back and forth pretty fast. But we can talk to our Italian colleagues, we can talk to our Korean colleagues, we can talk to people in China, we can try to figure out what went right and what went wrong there. And we're really learning a lot here. So I think we're using, not only are we building more ICUs, but we're using techniques that, frankly, I had only read about in books, of keeping people prone and doing percussion techniques, which are very old-fashioned techniques, but they're keeping people from getting intubated. And once they have a breathing tube in, their chances of coming away from that and coming out of the hospital is very low. So we see asymptomatic people, so people walking around right as rain, or maybe they had a little cough or a little fever, something. We see people presenting with a lack of sense of smell. So for those people watching, that's actually a hallmark symptom of this disease. So a girlfriend of mine texted me about 5-6 days ago maybe, and she said, you know, I made bacon this morning and my husband, who's also our friend, couldn't smell it at all. And I said, he has COVID. If you have no nasal congestion and you can't smell or taste, that's a hallmark. And it appears to exist in about 65 or 70% of people with COVID, where their really only symptom or their very first symptom is this lack of smell, which is the same as lack of taste, because smell and taste are sort of the same thing. And that has to do without having nasal congestion. So if you have your allergies and you can't smell because your nose is blocked, that's really different than having a clear nose and you can't smell. I think having the trouble breathing, people who've had that medium disease where they haven't had to go to the hospital, but they're really sick, they describe it as having their lungs on fire. So there's a real inflammatory response. And I mean, it is like taking 3 or 4 or 10 flus and putting them all at once into your body. So people really describe a terrible intermediate disease, but at least they're staying out of the hospital. And then the hospitals are seeing these really bad cases. And every place in the hospital has turned into an ICU. I think Governor Cuomo said that in New York today. He said, I can't really look at ICU admissions because the lobbies of the hospitals are now ICUs. So every bed is almost an ICU bed. I think the one thing that physicians are doing is we've adapted to telemedicine. So you can actually see your doctor or see a doctor, because we're also taking new patients, and ask them these questions from the safety of your home, so you can maintain your physical distance and still get health care. Most patients don't want to go anywhere near a hospital or a doctor's office right now, and I can't blame them. And I think the other point is that it is very lonely to be quarantined, and it's very lonely and isolating to be afraid and quarantined. Right? So nobody knows what to be afraid of. And Dr. Weiss is right. The virus does stay on like aluminum poles or metal poles, like in the subway. So now you can't touch the subway without wearing gloves. You know, maybe your neighbor can't lend you their crossword, their jigsaw puzzle, because it stays on cardboard for some amount of time. So there's a fear of the unknown. There's the loneliness and isolation that we all are feeling. And then if you have an underlying mental health issue, that can be made much worse. And I think telemedicine and telepsychology and telepsychiatry has been very helpful. I think just checking in on your neighbors, just giving a call, doing a FaceTime, sending a text, really allows us maybe not to physically hug or touch each other, but emotionally do that.
No, those are excellent points, particularly the last about the loneliness, right? And the stress and anxiety that you can layer on top. I would love to hear, I think there's a confusion because, and maybe if we can re-emphasize this point that I think Dr. Weiss made earlier, there's confusion because people are saying, well, we are socially distancing. We are doing all the socially isolating. Why are the cases still going up? Why are we seeing, today in Bergen County, it was 10,500 confirmed cases, 550 of them have passed away. And we see in Sussex and Warren, 400, 500, with a good percentage of folks, unfortunately dying. So people are not understanding why we still, if we're flattening this curve, why do we still see the rise in cases? Does anyone have very quick answer to this question?
It's because of what's behind the cases you're seeing. if you look at who gets hospitalized, those people are already significantly ill. That means they probably first acquired the virus on the order of 2 weeks before. We don't know the exact time intervals, but it's not a day, and it's probably not a week, but probably more than that. So, and then fortunately, some of the people who get into the hospital, we're able to save them, treat them. And the hard number is the unfortunate number of deaths we have, but that lags further behind after many of the people became severely ill. So what we're talking about is still seeing the cases occurring from weeks ago.
Yeah. So it's kind of a window into the past, really. Our present moment at the, is really a window in the past. So the kinds of things that we're doing now are really going to, we're going to see them in 2 weeks, essentially.
Right. The good news is from the dampening of the curve, you don't see a doubling of cases now, right? You see it flattening out a bit. That's really good news, suggesting that some of the spread has come down a bit. But when you hear about the fraction of tests that are positive, they're testing for evidence of the virus itself by RT-PCR, looking for the RNA of the virus. It doesn't detect whether it's alive or dead, that test, but if you have it particularly early on in symptoms, that's because the virus is replicating. The percentage of the tests that are positive right now is pretty high. That suggests to me that there's still quite a bit of ongoing transmission that happened fairly recently, and that the average person, if they weren't social distancing, would have a significant risk of coming in contact with someone who might still even be asymptomatic and then catch it themselves. So we got to be really careful about that. And there are a lot of social implications of some of that. So say you had a family, you had parents, and one of them starts to get ill, the other one starts to become ill, they may need to be hospitalized, and they have a couple of young kids in the household. You don't want to be sending those kids to the grandparents to be taken care of, because the young kids are very likely infectious, and those grandparents might not survive the infection at all. And we have to begin thinking socially, who's going to take care of each other in our society as people begin to get over the infection, and then those people can help out with others.
So actually, there's two types of tests, Arti. There's the test to see if you're actually infected now, right? And we're not testing enough people for that. So our hit rate is pretty high because we're not testing enough people, which means we just don't know the real number. But then the next test is going to be the antibody test, which is a blood test. And that test will hopefully allow us to know who was infected, who is now immune, at least to the current strain of COVID-19. And that, because, we talked about health, but we do have to talk about the economy. People do have to get back to work. I mean, talk about being anxious about being sick and anxious about not meeting your bills. And we see the lines going to food banks. So if we can start opening up our society again, maybe with those people who have shown that they have some antibodies, maybe that's the way, or we get a sense of what percentage of our population has been exposed, then we get a handle on how we open up our world again.
So I have a follow-up with that, right? I mean, that's a really important point, right? So we have one type of test, whether you have it or not, which not everyone is getting, right? We already know that. Folks who have mild symptoms definitely are not getting them. People are saying stay at home. So some of that high percentage, high positive, Dr. Weiss, might just be that these are the folks that we're almost sure have COVID-19 right now. And therefore we're getting them tested just to confirm. We know that folks who are asymptomatic clearly didn't, get them. So we have no idea really how many people are infected. And then the other part of this antibody test that you're talking about, with immunity, we're hoping that folks who have had it before have immunity, and have immunity that's long lasting. And we're hoping that those folks who had a mild case that were not tested for it in the first place, or folks who are asymptomatic and may have built immunity for it, will detect with an antibody test. So any of you want to comment on the status of the antibody test right now, and and whether or not we even know whether we're getting them? I know NIH has a trial for that coming out. I know that at least for asymptomatic folks in terms of antibody, and they're just started advertising this, I think, on Friday for asymptomatic individuals. You can do self collection of blood, send it in, and they would test for antibodies. So to me, that indicates it's a very, very early stage. So I'd love to hear, what you all know or understand about this. Anyone want to take
I've
that?
heard many politicians, scientists, people in public health talk about the hope of the antibody test, and I think it's premature. There are many assumptions that are being made. What we need is some good science, some good studies to find out what the meaning is. And each of the different antibody tests is likely to have different attributes. And how you would use that test, we need to learn how to define. Just because someone has antibodies detected on some test does not mean that they're going to be immune. We don't know that yet. It's the hope that we would have a test which would help us in that. But it'd be vastly premature for someone to get that test, be told they have antibodies, and think they were safe. We will probably need a nuanced approach to tell people what they can do and in what settings. And public health, that's extraordinarily hard to do. Usually you want to have one clean, simple message for everyone. And because of the severity of the current epidemic, we had a clear message, which was that we need to have massive social distancing and closing things down. How we reopen is what the CDC and others are going to be concentrating on and trying to help us figure that out. We're going to need a lot of testing, but we're also going to need careful evaluation of those tests. The tests can sometimes turn positive, turn negative, turn positive again. We've seen that part of that may be a sensitivity of the assay, could be limitations of the assay. There are other forms of coronavirus. Early attempts to develop some of the test kits had problems because of cross-reactivity with those other variants of coronavirus. So I've had calls from people developing lab assays, wanting me to go back to my research banks prior to the COVID epidemic, so they would know they'd have a group of specimens they would know are clearly going to be or should test negative for this virus, to be able to test out their assay to know whether their assay is detecting this particular variant.
So I hear you that the antibody tests are not the silver bullet. And I hear that perhaps the testing to see if you have COVID-19 is not 100% accurate. And being a scientist and an erstwhile academician, I completely get that, right? And I understand that. So is there a leg or two or three for us to stand on from a public health perspective, from, can we make best guesses as to when that flattened curve is going to allow us re-entry? So Sujana or Thomas, either one of you want to take some of that?
I think it's going to take still quite a bit of time. The point of flattening the curve is to reduce the number of people who are actively infected so that our healthcare institutions would have some chance of caring for those people. The second aspect of flattening the curve is by delaying when some people would be infected. We hope that we'll have treatment that's better than we currently have. And so therefore we could better care for many of those people. And indeed, even those who become seriously ill have a better chance for full recovery. So for all those reasons, flattening the curve makes sense. But I doubt that a high percent of our population now has already been exposed, infected, and immune. That means as soon as you begin lessening the social distancing, people are at risk of contracting infection. So we have to have a very careful approach about letting people know what they should do. So those people who are at highest risk of progressing to serious disease and for whom we don't yet have new treatments yet and we don't have a vaccine, I think those people are going to have still fairly extensive social distancing for many months to come.
Mhm.
I think we should be able to take people who were symptomatic with COVID-19 and or had a positive test for the virus and let them, as soon as they're feeling better, enter the workforce. We've already been doing that with some of the early exposed and infected healthcare workers, other first responders. We need their help back online. But that will also apply in all sorts of other modes of work. For them, we think that it's going to be safe for them to get back in the workplace.
Mhm. So we have a bunch of questions, and I'd love to get at least a few of them answered before we go on. But before we do that, and I think some of this is probably going to come into play with the discussion that we've been having as well. So we're going to try and keep the answers as short as possible. Just so we can get through as many of them as possible. So Debbie from Wyckoff asked, while walking in my neighborhood and keeping social distancing, do I still need to wear a mask? And I'm assuming this is one of the fabric masks, since N95s are hard to come by. Sujana, do you want to take that one?
Yeah, I'm happy to take that one. So the answer is, if you're walking alone or with a person who lives in your house, you don't have to wear a mask. If you're going to go into a store or interact with anyone who is not living in your house, yes, you should wear a mask and maintain your 6 feet or more of social distancing. But getting some fresh air, talking about the psychological effects of being cooped up and being trapped in your house and away from your normal life, the more you get some fresh air, the better.
Great. And I know that now we have an executive order from the governor that means that we have to wear them when we go into stores as well. And the point is to not necessarily not get them from someone else. The point of the mask is to make sure that if you're asymptomatic, you're also being careful about not necessarily transmitting that easily to other folks as well. And that's
and be sure, and use, like you said, the cloth masks seem to be adequate for if you're an asymptomatic carrier and if you're, interacting with the cashier at the grocery store. If you've got a mask and they've got a mask, the chance of you giving each other virus is very low. You should, with the cloth masks, be washing them in hot water and soap after you use them. So once you come home, take off your mask, wash your hands for that 20 seconds, the longest 20 seconds you've ever spent. And make sure you're washing your mask. So I have a couple of the cloth masks around.
And I really want to emphasize, right? The CDC guidelines are wash your hands for 20 seconds, like Dr. Chandrasekhar just mentioned, social distancing. So the fabric mask that we're talking about is on top of all of that, is on top of the things that we're doing. I really want to emphasize that this is not in lieu of, there should not be a false sense of security because you're wearing this mask. And that should not be, an excuse to go out and hang out with friends at a closer distance than that. This is definitely something that I emphasize with my kids, but it seems as if adults need a little bit more of reiteration of that point. So next question.
Wait, one more thing I want to add to that. If someone is sick, they're coughing, sneezing, breathing heavily, you cannot go out to the store and wear a surgical mask and protect others. There's a study which demonstrated that with that type of breathing, that the mask did not protect from the virus spreading in the environment.
Yep. Excellent point. Thank you. All right, next question. How long after being diagnosed do I need to stay in quarantine? So this particular Zunilda from Rochelle Park mentioned that she had symptoms April 1st. She got tested April 7th and got got her test results April 10th. So this question is, how long to stay in quarantine? And before anyone answers, I do want to say that this particular medical advice, you should always talk to your doctor. You should always do that first. And these are just general guidelines for folks, just so they're aware. And this is not a personal recommendation from one person or another, but with general guidelines. Anyone want to take that one? Thomas? or Sujana, either way.
Oh, so I mean, this is sort of a difficult answer to give because initially, you know, the CDC had talked about being 14 days, to wait 14 days. However, there are some papers coming out which have indicated that some people may harbor RNA still, not clearly if they are infectious still, but as long as a month or a little bit more even. So that's preliminary. And I think a lot of this is, you know, a lot of this is predicated on the fact that we don't have a lot of experience with this virus yet, despite the fact that we have so many cases. It's only been a few months that we really know about this, and we're actively trying to figure out what is the best thing to do for it and trying to figure out what the course of this virus is, since it is so variable, ranging from people who are completely asymptomatic to a little bit of a cough to severely hospitalized and to death. So that's we're still trying to figure out exactly the best things to do.
So, but 14 days is sort of the standard, yeah, Dr. Chandrasekhar?
So 14 days from the first symptom, but then the CDC has criteria, temperature less than 100.4 for
Okay.
3 days. So
Okay.
not 104, but 100.4 with 98.6 being normal.
Mhm.
So if your temperature is under 100.4 every day for 3 days, and they say that you should take it twice a day, then you are considered to be on that sort of tail end, you know, that tiny bit that Thomas was talking about, but you're considered that you don't have to stay in complete quarantine.
So if
In my opinion, the CDC is not giving the best evidence and best advice on this at this time.
Hmm.
I would time not from when someone first got infected or was first symptomatic, but start the clock from the point when you have no symptoms, no fever. And to me, that's no elevation of temperature, not a clinical fever 100.4, but a normal temperature for that person. So they're not coughing, they're not feeling that they are in a situation where they could be more actively spreading, and then start the clock. Some people have said 3 days is enough. Some hospitals I know of are using that as a criteria. That's possibly correct, but I would think we should be more conservative in the lack of having definitive knowledge,
Hmm.
and would think at least a week and perhaps even 2 weeks from the absence of having any symptoms and fever. Now, symptoms like continuing fatigue certainly can occur, I think, for many weeks at least after the infection is resolved. So I don't see that as a sign of active infection.
So is this, so I hear even among experts and healthcare practitioners that there is no clear guideline. And so this must be really tough as you're trying to take care of patients and trying to share, you know, what the best way is to take care of folks. So I can imagine for lay people, for folks who have or, you know, who feel like they might be having some of the symptoms, that this must be particularly difficult. So I want to actually, you know, ask a follow-up question to this. So let's assume we're being as conservative as possible, as Dr. Weiss mentioned. So, you know, cessation of symptoms. Couple of things, you know, should folks that we've identified as being more vulnerable, so people who are, you know, seniors, people who have underlying heart, lung ailments, diabetic, you know, those folks, should they wait longer? Is there any guidance on that? Or you know, are there things that we should be thinking about for those folks, particularly, you know, when we are, as they're recovering? Dr. Chandrasekhar, do you want to take that?
Sure. So I actually think our concern is not for the older people who've been infected, because
Mhm.
unfortunately their course is usually worse.
Mm.
More consistently than a younger person. But, you know, we've seen bad disease in 20s, 30s, 40s. But we know that when you're older and you get the virus, you do worse. But the concern is the 40-year-old who gets better. So the person who wrote in the question, who's now, you know, feeling well, and it's 2 weeks later, and let's say she has no fever. However, if she's still shedding or she's still contagious, then, and she's not taking precautions, she may then infect the older person that she runs into at the grocery store, right? So that's the concern is even if you've recovered, you still need to be using the social distancing. You still need to be wearing the mask. You still need to, cover your cough with your elbow. You still need to wash your hands. You still need to take your shoes off when you walk in the door, because they've shown that just like other inanimate objects, the virus stays on your shoes. So I think it's less the older person with the relapse than somebody going in and inadvertently infecting somebody before we can be sure that they're no longer contagious.
And so we don't really have an idea right now of when that is really what I'm hearing. So we're thinking it's 2 weeks to a month.
Yeah, the CDC is saying 7 days since the last cough or dyspnea and 3 days since the last fever.
Got it. So those are the guidelines that we're going with. Great. I think that kind of segues into what is going to be I can't believe our last question, because this has been, I think we could go on for a very long, there's so much to do here. And so the question from Jane from Haworth is there a time frame for the quarantine? What are the steps that our community is taking to move past the quarantine? How can we begin reintegration into a social environment, including work, school, etc.? So there's a lot here. And I want to frame that in a couple of different ways, I think. So we talked about how for this, we need testing to really be able to see how many folks are infected, flattening that curve. Dr. Weiss, you talked about how that is buying time, right, for us to be able to think up therapeutics and figure out what is working and not working. And then eventually, I think 18 to 24 months from now, at the earliest, is the hope of vaccine. But the idea of shutting down the economy for 18 to 24 months is, it's just untenable, right? However, going back too early, we know can have severe consequences. We can have a second surge, is what we're seeing with other places like in Hong Kong, where there's a second surge of infections, there's a second surge of hospitalizations that's taking place. So how do we make sure that we don't, put gas on the fire, as it were, and accelerate this or come back up to the steep curve that we have, and make sure that our hospitals and our healthcare workers are not inundated as much as they are now, while at the same time trying to figure out how we go back. What is the science that we should be following? What are the signs and symptoms that we should be looking at? Any thoughts on that in terms of coming out of this in terms of reentry? What are some guideposts? So Dr. Krivik, Thomas.
Sure. I mean, I think that one of the big things that we need, and we've highlighted this a lot, is testing, because if we want to start reintegrating people, we're going to have to understand about how many people are asymptomatic but positive, So that is a tricky question. And right now our testing capacity is woefully inadequate. We likely will need tens, if not hundreds of millions of tests almost done.
We need to put our resources in getting rapid tests as much as fast as possible. I mean, I've heard numbers of like 750,000 on the low end per week to, something like millions. So is that something that you agree with, Dr. Chandrasekhar, as well?
Yeah, I think the testing, without data, you hear from you're listening to 4 people who love science and are nerds, and we're all grasping at straws because we don't have the data in front of us. I think in terms of reopening society, some of the hotbeds of infection or transmission are college campuses and dorms, are schools, and frankly, the colleges have made that decision for us, right? Every college is closed. I have a son who's graduating from Syracuse University in May, and he'll graduate, and hopefully everything will be back to normal, and they'll have a ceremony in the fall. But I think the colleges removing the sort of a cesspool, and the schools of transmission and then coming back and either infecting mom and dad or grandma and grandpa, that was very helpful. And so then we can say, okay, let's then, great politicians like you have to weigh health and economy and work product and everything. And then we have to say, okay, we've had retail, we've had grocery stores open. What's the next level of retail that should be open? When do hospitals get the burden lifted and doctors' offices open properly again, right? So then we can do, when do banks open again? Have you tried to go to a bank in the last month? It's amazing. Yeah. Like you can't get in. Whatever it is you want to do at the bank, it cannot be done at the bank. You have to go call a number, right? So at some point, those services have to be opened up again. And I think we do have some time because the kids from elementary school all the way up through college and graduate school are actually not part of the equation for the next 2 months. And I think that buys us some time to get the testing, to get the data, to know how to counsel these people, because frankly, we want them to go back and live their lives and do the things, my college age kids don't need to be living at home with me, right? And I'm very lucky they are, but frankly, they need to go away. So I think we have some time built in where we can make those decisions.
Yeah.
And some of the problems with testing are starting to get resolved. I mean, we definitely have seen situations where another problem is that tests were taking more than a week till we got responses. Now, and that's just completely unacceptable, because how can you not tell people when you know that you have asymptomatic positives, that you can't get the rapid responses? And there are now rapid tests that's been developed. They're still in short supply in terms of being available. I think, I saw one question on the board also, someone asking about, the fairness and equity of distributing the tests. And I think that's also a real concern, because there definitely has been some preference showed. Witness the fact that the NBA was able to get all of their players tested very rapidly, whereas a lot of people who are having severe symptoms are still not getting tested.
Yeah.
So far in this epidemic, we've sort of talked about individual aspects and concentrated them. We talked about the need for people to be intubated, having that equipment available. But you need a systems approach to look at all the different aspects in combination. One of the big things about having more tests would be when you identify someone after things had calmed down who's infected, to do the extensive contact tracing, which we lost the opportunity to do the last few months, but with the reopening of society, which we would need to do in order to find out who all the contacts are. Well, we have a problem. We don't have enough people in the public health workforce, because that was decimated over the last decades by administration after administration. It's been documented in the literature for more than 2 decades about that deficit. We don't have people currently trained who can do all of that contact tracing, and we've got to ramp up to do that rapidly, or else doing all the testing isn't going to help us really ramp down and keep things under control. The other issue that we have to think about is all the manifestations. Well, if kids are at home, parents need to be home to take care of them. They can't get necessarily out to work. So we have to figure out, well, who's going to take care of the kids? What are they going to do? Well, if you have the kids all congregating, whether it's in school or in camp, and they're home part of the day, then they're in camp. If one of the adults gets infected, we know that the chances are the kids very often won't be symptomatic, and they can spread to other kids and bring it to other households. So we have to figure out now what our social resources are, how we'll step that up, how we'll enable people to get to work and still take care of all of our kids, and when a case occurs, to be able to rapidly react to it. So all these things need to happen very simultaneously, not in a piecemeal fashion. So we need a real big step up in the help that we're able to give to local health authorities, because they are overwhelmed right now. you've heard much about how the hospitals are overwhelmed, but I can tell you from all the people in public health, they are severely overwhelmed.
So Arti, I know you've been really proactive about reminding people to fill out their census forms and saying that, and now all the census workers, census takers are not going door to door. My mother, who is very smart, I hate to say that out loud, was thinking, we have a potential workforce. We have a potential public health force like this. Like once the testing is easier, we have people who are willing to go door to door to collect census information. That's something that the government could really help us with, is allowing science to flourish in terms of data. So then we will know who can go back to work, who cannot go back to work, where the children should be taken care of. Kids are home from school for the next couple of months, but man, kids need to go to school. Like there's a lot of reason we send our people out of the house, and we need to resume that when we can.
Yeah. No, that's a really good point. And, we've talked a lot about public health being woefully underfunded, and I agree with that. And science and needing more data. Clearly, we need more information, more real data that we can base our facts on. I think, of course, we have to balance that with privacy concerns and in terms of the kind of data we gather and from where. And I think that one indication, I will also add to that, is that one area, even amongst the data that we don't have, one thing that we seem to know and understand is that communities of color in particular are actually harder hit by shocking amounts, right? When we look at some of that data that comes out of New York, and even some more that just recently came out of New Jersey, we see that they are shockingly overrepresented in terms of worse outcomes with COVID-19. And I think that really points to our systems that are in place. I mean, systemic racism has put things in place that really reduces the kinds of determinants of good health that we have elsewhere. And I think that those data that we have really tell us where else we should be allocating our resources to, and who else that we should be thinking about in general as well. So I don't know if this is what you've been seeing with your patients, but we see that all across the board. And if that doesn't wake us up, I'm not sure what will, because a pandemic on top of all the things that are happening is literally killing people at a disproportionately higher rate, which is not something that we should tolerate as a society. And I think that census data in there is helpful. So, well, it looks like
so fill out your census is what you're saying.
Fill out your census, and also understand that even as we are all suffering and we are all dealing with this on all these different levels, that we still have communities that are disproportionately worse off because of the systems that we have put in place. So we have a choice, right? With this pandemic crisis that we have now, we have a choice from when we start going back, and we will hopefully, and I will advocate, as we all will, to follow the data and the science to figure out how we're going to go back and what that reentry is going to look like. But we have a choice then of figuring out how we're going to rebuild the system and how we're going to rebuild the society in a different way. And, at least from my perspective, and I think from a lot of our perspective, the choice will be to fight to have more equitable society and more equitable systems that we start putting in place, both in terms of who we value, how we value them, and how we allocate our resources to make sure that there is much more equity, particularly in our communities of color, particularly with, minority communities, particularly with women and other vulnerable populations. So, that's my take on how we come from here. And we do need to fight for policies that are going to make us more resilient in the future. And to me, that also means a stronger social safety net. And I think we see evidence of that, across the board with this crisis, at how we haven't even touched on the economic impact. We haven't even touched on, essential workers, like grocery store clerks, and folks who are working, who might have to go back to work no matter what, and are still worried about things like rent, and putting food on the table, and wondering how, those things are going to happen, while some of us are able to work from home. Not everyone is. So, and that's a reality that, that is clearly being shown now. And I think that a lot of us have opened our eyes quite a bit more to that. So, but I appreciate it. We have so many other questions that we didn't even get a chance to get to. But this was a really, really important discussion. And thank you so much for giving your expertise here. We have a list of questions. We will, I promise to everybody who's tuned in, we were live streaming on multiple different platforms. So we had, I think, 200 plus RSVPs to this, and we had hundreds of other folks tuning in. So clearly we had a wide audience with lots and lots of questions that we will get answers to and get back to you on. But a very important thing that I wanted to share is that for those who are looking for resources, we have resources on the Arthi for Congress COVID-19 page. We have mutual aid, those who are looking to find ways to help, and those who are looking for help. We have forms up there for mutual aid. We as a campaign, me as a person, we're all committed to doing everything we can to help the most amount of people that we have. So we have a lot of information on our website. We also have a lot of ways of getting involved and asking for help. So if you need help, if you know people who do, please fill out the form. We will connect you with the right people. And it will be based on science and data and the best guidelines that we have at the moment that we're looking through. So thank you all. Dr. Weiss, your epidemiology background was immensely helpful. Dr. Chandrasekhar, clearly learning firsthand about all the different things that are taking place was enormously helpful in understanding, where we're going with this. And Dr. Kreibig, while you did have to be part of this panel, your expertise was also very helpful. And I think for all of us to understand, where we are and where we hope to be. So I am so grateful that you are part of this. And thank you very much.